respected chairperson, independent awardee, Professor Brigadier Januna Fatima Madam, then Professor Jahid sir, Professor Abdul Salam sir, Professor Abdullah Shahriar, and Professor Tariq, and all other distinguished guests here. Assalamu alaikum, and welcome to all of you to our today's IPDI presentation. And I'm just going to present a very simple topic, that is atrial septal defect closure, a special variety of atrial septal defect closure. It is not working. Slide change. Special variety of atrial septal defect closure, that is sinus venosus atrial septal defect by the minimal invasive cardiac surgical technique. It is not working. Not moving, please. Not working. Now it's working, yeah. And this is Dr. Mohammad Rokonujjman. I'm working in Ibrahim Cardiac Hospital. This is my hospital where I work. And it's very well known that is a size don't matter. It was told by there is a famous writer, but that is only for chopping wood. Size don't matter. But if you look at the latest surgical innovations or latest technological innovations, size really matters. If somebody is offered this kind of mobile in these days, I think nobody will be accepting it. And in the management of atrial septal defect, it is managed by the cardiologist nicely in most of the cases, and those are second-term variety of atrial septal defect, few cases. And minimal invasive cardiac surgical technique is applied for the atrial septal defect closure, mainly second-term variety all over the world. And this is the minimal invasive technique, where this is the conventional scar that you find during the sternotomy, and this is the minimal invasive technique where we get the scar either here or under the axilla in various ways. And this MICS technique is not practiced for the sinus venosus and primum ASDs for in most part of the world, but we are practicing in our center. There is the minimal invasive technique for the management of sinus venosus ASD and primum ASDs as well with the PAPVD. And you know, all of you know about the advantages of minimal invasive cardiac surgery and shorter hospital stay, small incision and all others, and moreover it is cosmetically more acceptable to the people. And there are some challenges in minimal invasive cardiac surgery. Of course, the learning curve is a very big challenge. Along with this, the establishment of the cardiopulmonary bypass, and the technique of establishment of the cardiopulmonary bypass is very much important. And you need a very close help from the cardiologist as well as the perfusionist and anesthesiologist. And this is the sinus venosus ASD, and this is the place of the ASD, and this is the PAPVD, which is commonly associated with ASD with PAPVD. And how do we manage the sinus venosus ASD normally? This ASD and the PAPVD, with a single patch, we connect it and we reroute this PAPVD to the left atrium through the single patch by this technique. And it is mainly managed by the menial sternotomy, but in our center we are managing it by minimal invasive technique successfully in most of the cases. And the main challenge of MICS with sinus venosus is the cannulation of the superior vena cava, because normally the superior vena cava we cannulate in the lower part, but here we have to cannulate a bit up, and the delineation of the anatomy is quite important in this case. And really we thank to the radiology department for delineation, where to give incision by the preoperative CT aortopulmonary angiogram. And this is the surgery how we do the MICS in our center. The incision is given in the front of the chest. Yes, now we are doing the femoral, exposing the femoral arteries for the femoral bypass. And femoral bypass is practiced in most of the cases of adult, but for the children we don't need to do the femoral bypass. We just use only the central cannulation through the fourth intercostal space by the incision under the axilla. Okay, we are inserting the femoral cannulus, and this is the view after the opening of the chest through the fourth intercostal space in the front of the chest, and the surgery is going on. And here we can see the superior vena cava is open here through the MICS technique, and this is the ASD and this is the PAPVD. Both are managed in a single stage. It looks difficult because in MICS the most important thing is that the pain of the patient is transferred to the surgeon. This is the ultimate scar around 5 to 6 centimeter after the surgery. And we did around 10 cases in last 4 years or 3 years, and by the MICS technique in adult. Pediatrics, we did around 20 cases, this Sinus Venosus ASD as well. Age range from the body weight up to 70 kilogram we did. And for the female, we use the addition, that is incision, we use under the axilla, not in front of the chest, not under the breast. We use the femoral cannulation. And this is the aortic occlusion time, and extracorporeal circulation time is quite standard, not very much high. And patients are extubated in the standard manner within 6 hours. And within 10th post-operative day, all are discharged for the home. And there was, we had a very good outcome. There is no residuals and no reopening heart block, which is the AC nodal block is quite important after the sinus venosus ASD closure. And I really acknowledge my anesthesia department and ICU department because they are helping a lot using the TEE and managing the patient, positioning and everything. And my sincere gratitude to the radiology and imaging department for visualization and planning of the surgery, perfusion and anesthesia and critical care department. And last but not the least, it is safe and excellent cosmetic and clinical results, and is psychologically more acceptable for the patients by the MICS sinus venosus ASD closure. And I'm really sincere gratitude to my two legendary professors of my hospital who really started the MICS program, who helped me very much and who are really helping, their help is continuing for doing this MICS program in my institute. Thank you very much.